So we studied the treatment of tricuspid regurgitation, which is a very prevalent disease and associated with poor outcome. And we looked whether we could improve tricuspid regurgitation by implanting the so-called TriClip, which is an iteration of the well-known mitral clip. We included 85 patients in 21 sites worldwide, and so far we have the 30 days follow-up. Yeah, very good question. We had two co-primary endpoints. First one was on safety. We looked at the MACE rate, and that was exceedingly well. We had at 30 days no death, no cardiovascular mortality, no stroke, no myocardial infarction, no need for conversion to open heart surgery. We had a few bleedings which were not fatal, which could be dealt with just with conservative measures. And we had some leaflet detachments in a few patients very early, but that didn't lead to clinical consequences. So safety was extremely favorable, and efficacy was also very promising. We were able to reduce tricuspid regurgitation in 90% of the patient for 1 or even 2 grades, in some patients even 3 grades. Up front, 90% of the patient had severe to torrential tricuspid regurgitation, and after the trial, almost 60% of the patient were at 30 days with moderate or even mild TR, so quite an improvement. Safety was pretty good, and major adverse events were very low. That was a very sick patient group, 78 years of age, anti-proBNP almost 4,000, but we didn't lose one patient, no cardiovascular mortality, no mortality, and no need for open heart surgery, for example. The TRILUMINATE study showed promising data for the TriClip in patients with tricuspid regurgitation, but of course that was a feasibility study and not a controlled trial, and now we have to go for a randomized controlled trial comparing medical treatment against the TriClip and looking at really hard endpoints such as mortality. Tricuspid regurgitation is first of all associated with poor outcome, so we have to do something. We have only diuretics, so medication which is very limited. Surgery is associated with very high risk. Mortality rates are as high as 20%, especially in the reduced situation if the patient underwent already an open heart surgery for different reasons, for mitral valve repair. And therefore we need something new to be tested, whether it can improve tricuspid regurgitation, and by this hopefully at the end of the day also the life expectancy of the patient. You should treat patients in which you expect a life expectancy of at least 1 year. Some patients have so many comorbidities that it may not make sense to treat these patients with such an experimental device or with a device. And other than that, for example, a patient who is suffering from severe pulmonary hypertension should also not be treated, because pulmonary hypertension is the disease itself, and that causes tricuspid regurgitation, and you would even harm this type of patient. And patients with others very severe comorbidities, let's say and left ventricular ejection fraction below 20%, so end-stage heart failure patients should maybe also not be candidates for that treatment.